Thanks for having me today. I'm a postdoc at Imperial College London, and it's been great to hear about all this amazing research going on, even remotely. So thanks for including me in the session. And today I'm going to be speaking about a metapopulation model we're building to study surveillance posts in border regions in sub-Saharan Africa. So a little bit of a pivot from the other two presentations. So my research team uses models to look at questions relating to malaria elimination. And so this is a map of the countries which have been selected by the World Health Organization, which have the goal of elimination by 2025. And when you look at the map, you can see that all these countries are on the fringe of endemic areas, and many of them still share a border with mid to high transmission countries. And then even within countries which have already eliminated malaria, international border areas have historically contained the last malaria cases. And this can be due to things like remote populations or migrant workers going back and forth or political complexities, which make it harder to provide care to these areas that are on the border. And then another key driver of transmission in these near elimination settings is human migration. And so movement patterns have been characterized in the past using survey data. And also from parasite genetic lineage data, we know that there are established transmission chains across international borders. And some of what we've seen in this already in the meeting in other presentations. And so one example is on the left where we can see that genetic links are occurring between Angola, Zambia, and Namibia and the parasites across those countries. And then we also know that mobile groups are at an increased risk for infection compared to the general population. And we can see this on the right among travelers from Bioko Island to mainland Equatorial Guinea, who have a higher odds of having an infection. So what do we do in these situations where a country is trying to eliminate, but we know that these transmission chains also exist? So we have two main strategies, and the first is to target the source population. And this can be done through things like regional initiatives to fund prevention and control of malaria in source areas. And then the second is to intervene during migration when people are moving or shortly after entry once they arrive. And this can be done through things like testing migrant worker populations or deploying mobile clinics for active case detection along these border areas. And setting up test and treat screening posts is another strategy for intercepting infections. And so historically, these border posts have been used on borders such as the Cambodia, Thailand, Laos border, Bhutan, India, the Elimination 8 region of Southern Africa, which is shown on the left, and along the China-Myanmar border, which is shown on the right in the purple and blue regions. And there are published descriptions of these border post interventions in the literature, but there's very little quantifiable evidence about the intervention's effectiveness. So this led us to design a metapopulation model to help answer this question. So our goals were to estimate the effectiveness of border posts on reducing cases of malaria among populations living in border areas, and to identify characteristics of the sites where the intervention would be the most effective. And mathematical modeling is particularly useful in this case because it's nearly impossible to disentangle the effects of border posts from the effects of other things that they're normally packaged with. So I'm just going to start by showing you a toy example to just illustrate how the model works. So usually we parameterize our malaria model to look at one country or one admin unit at a time, but the metapopulation aspect lets us run different models simultaneously and capture mixing between the units. So in this example, the three colors represent different transmission levels in three different units, low, medium, and high. And then these matrices at the top represent the level of mixing between them. So in the isolated situation, each unit has no influence on the others. So you can see that all the lines are just distinct. And in a perfectly mixed scenario, all three settings eventually end up having the same prevalence. And semi-mixed scenario in the middle represents reality, where there's some level of influence, but each setting still has its own distinct transmission pattern. And in the model, there's no actual movement of individuals. So we're just simulating this by using these values in the mixing matrix to guide how much influence each setting has on the EIR and then on the force of infection on mosquitoes in other settings. So then the next question became, how do we figure out how to create a mixing matrix to accurately represent real life? So we started by identifying all the first subnational admin level units in malaria endemic sub-Saharan Africa. And there are 44 countries represented which touch an international land border. And then we classified all these admin units into countries which touch a border, which are shown in red, and then ones which were in the interior of a country, which are shown in orange. And then we created clusters of 8 with each of the 401 border units functioning as seed points. So this is an example cluster where the seed point is shown in red. And then we identified the 3 nearest national neighbors, which are the orange points, and then the 4 nearest international neighbors in blue. And then these points comprise one cluster of 8 units. And so we chose this smaller number of units just to make it more computationally feasible, just because modeling all 401 at once would be a lot. We then needed some way to measure how people in these units are interacting. And so one of the factors in this was this land-based travel speed friction surface from the Malaria Atlas project. And you can see travel times in minutes to cross each pixel. And then that lighter orangish color shows the border, and it's just an added penalty time for crossing those pixels. And then we also captured the population size using data from WorldPop. So we're working at the admin1 unit as the smallest area available to parameterize the model with things like historical intervention data. But because admin ones are still pretty large and often still have lots of malaria heterogeneity within them, we tried to work at a finer scale for building the mixing matrices. So we overlaid a 0.1 by 0.1 degree grid surface on the top, and then calculated the population within each grid cell, and then also the travel time between each cell to every other cell. And then combining these two things, we calculated mixing matrix values using a gravity model, which was dependent on the population size and the travel time. And then we aggregated the mixing between all these grid cells back up to the admin 1 level to get a final 8 by 8 matrix to use. And then we also incorporated 2 additional pieces of information from DHS surveys. So the first was the probability of overnight travel in each admin 1 over the last 12 months, which varied quite a bit even within countries. So a mean of 0.43, but a range from 0.08 to 0.75. And then the second piece of information was the mean number of overnight trips, which is a little bit more constant between countries. And then to build our intervention into the model, we created this process where a certain proportion of the traveling population is checked by a border post. So in this case, we set this at 80%. And then a certain proportion of infections are picked up by an RDT. And then a proportion of those with positive tests are treated. So in this case, 95% with AL. And we also set it up so that the sensitivity of RDTs is dependent on the underlying parasite prevalence. So higher population level sensitivity to infections from high prevalence areas, and then there's lower sensitivity to infections in low transmission areas. And then just a note that the interventions implemented only along the international borders, not within any subnational divisions, even though these could still be important. And then just a reminder that the model is not moving individual people, but it's just incorporating this mixing through influence on the EIR and the force of infection on mosquitoes. So here's what we got after running all the simulations. And you can see that the absolute number of cases averted varies widely across the continent. But you can see that they appear to be the most effective in areas like the Kenya, Ethiopia, South Sudan borders, Rwanda, and then the Western Cote d'Ivoire regions, among others. And we can't necessarily interpret these results as recommendations for specific areas since we don't have subnational data on human movement. And this is a very optimistic, universally applied coverage value of 80%. But you can see that the emerging pattern seems to point to areas of low transmission that have higher transmission neighbors. And then we see similar results and geographic trends when we're looking at the percent of cases averted and then the percent reduction in parasite prevalence. And both of the measures are quite small. And so this is partly because the intervention misses some cases that are still passing through, but also because it's only applied to the small proportion of the population which is traveling overnight at each time step. And so most of the population stays mixing within their own unit. And then we can also look at these data in terms of resources needed. So a median of 14 people would need to be screened at a border post to prevent 1 case, but this has a wide range depending on the place. So in low transmission areas with other low transmission neighbors, thousands of people would need to be screened to prevent 1 case just because there's not very many infections in the population. And then in high transmission areas, it would take very few because most people crossing the border would end up testing positive. And then so far, I've been showing results from models parameterized to specific places in sub-Saharan Africa, but we also ran some case studies to look at this relationship more in depth. So here we have a 2-unit model that's varying levels of baseline parasite prevalence and allowing for 5% mixing. And you can see that the highest percentage of cases were averted in the upper left-hand corner, where extremely high transmission areas bordered extremely low transmission areas, and then very few cases with the low-low pairings. But in reality, we know that these types of extreme scenarios are not common, and the pairings look more like this with more moderate differences in transmission. And then we also ran a second case study to look at the sensitivity of outcomes to border post coverage levels. So it's the same 2-unit model, but unit 1 is a low transmission setting of 10%, and then we vary the levels of baseline parasite prevalence for unit 2 on the x-axis from 20% to 80%, and then the border post coverage on the y-axis from 0 to 100%. And so you can see that the proportion of travelers screened does influence the overall cases averted. And if this intervention were to be implemented, it would be important to cover highly frequented travel routes or specific populations which have high risk of transmitting infection. And I guess, yeah, border posts would not be very effective when they're missing most of the infections that pass through to another country. So a number of key findings came out of this work. First, that the border post intervention did avert cases and reduce parasite prevalence in border areas. And differences were small, but the impact was dependent on the difference in prevalence between neighboring units. And the intervention that had the most impact in low transmission area where it was in low transmission areas that had high transmission neighbors. And then thirdly, we see that the border posts will not be the magic solution to allow a country to reach elimination. And this is partly due to the reality that only a small proportion of people are mixing internationally at a time, and also that RDTs are not sensitive at a population level in lower transmission areas. And then the primary limitations to analysis are lack of data on implementation costs and feasibility. So it'd be difficult to implement this intervention without knowing how the cost effectiveness compares to spending money on other things. And it would also be important to know how easily border posts would be able to capture most travelers flowing between settings, and if mobile populations would be amenable to being tested in the first place. And then we also know that admin 1 units can have a really big difference in land areas in some countries, and so it's not a consistent way of measuring a space. And we chose admin 1s for the project because it was the smallest unit available where we could get data across the continent on things like historical interventions. But we are working on figuring out another solution for country-specific modeling, which won't need to use such a big land area and can use finer scale data. And then we're hoping that future work could compare border posts to other forms of regional collaboration, like resource sharing or synchronizing BINET campaigns or vector control. And we can investigate integrating this intervention alongside other things like tracking drug resistance or screening for other infectious diseases. And then finally, this has just been a good exercise in building out a meta-population model, and I'd love to hear suggestions from other people in the room who are working in this topic, or just have other ideas for application, because we're a little bit at the beginning, but I think we'd like to expand for other uses. And I'll just end by saying thank you to the people who've worked with me on this project and to our funders at Wellcome Trust and the MRC Center. Thank you.
Thank you. Questions?
Hi, thank you very much for your presentation. When I think about migration and migrant workers and malaria, I would assume that depending on the context, there's probably overrepresentation of one gender versus another amongst migrant workers. And I was wondering if that data on gender existed for migrant workers, but also for malaria cases, and if you had thought about integrating that into your model.
Yeah, that's a really good point. We don't have gender integrated right now, but what you're saying is true, that there definitely are gender differences depending on what groups you're looking at. So I guess for migrant workers, I haven't seen anything that's continent-wide for this project as of yet, but I guess still should be on the lookout for that. I've seen some data on gender differences just for, I guess, international populations traveling generally, and it definitely is more men than women, but I guess not as much as I thought it would. I think maybe still high 50s. But I think if you were looking at a specific population, migrant workers especially, it would heavily skew towards the male gender. So I think that's something that we would need to incorporate, especially if we're doing something country specific and trying to make specific recommendations.
Any other questions? I have one. So I was curious, like in most countries, how easy is it to track people who don't go through official border posts? Is there an estimate of how many people just cross the border and they don't know where they're crossing from? And how would you target?
Not that I've seen. Yeah, I think that's just a huge limitation is that I think people don't know and there's not really a lot of data on that. I guess we've looked into trying to get things like Facebook data or other mobile phone tracking things. So I've seen some projects on that for national studies. I haven't seen anything about it for international border crossings. But yeah, I think there's just not that much data that exists. So if we were doing something country specific, I think it would be important, I guess, before attempting this to be able to get some sort of measure of that.
Yeah, this is it's a great project and well done. I was keen to learn more about the data collection, most of the movements that you got. I think I missed it. Did you say you picked it from the DHS system? But the other thing I was keen to look at is, do you think the generalized linear mixed methods model would do better than the gravity model you used?
Yeah, those are good questions. Thank you. So I guess we didn't have any specific data on population movement. So that was partly the purpose of using the gravity model was to find some other way to estimate it. So the gravity model, the parameters we took were from survey data, which just surveyed general populations in 4 countries in sub-Saharan Africa. And then we adapted it by using population data from World Pop, assuming that people are more likely to travel to major population centers than rural areas. And then also this land-based travel time friction surface from MAP, just to try and get a sense of how difficult it would be to move from one place to another. So those are assumptions that we made and like I guess regional data sets that we used because we didn't have any actual data on population movement in this case. And then yeah, that's a good question about the gravity model. I think we should be looking at alternatives. So I guess another thing we've considered is a radiation model, but I think maybe it's similar limitations to the gravity model. But yeah, I think it would be good to try some other things as well.
All right. Thank you, Hillary.
Yeah, thank you.